patient and see whether there is any contraindicating or constant medicines are going on. Also, I see that whether suppose patient is going to a surgeon for diabetic foot and he is prescribed diclofenac for some inflammation, or orthopedic surgeon for frozen shoulder and he is prescribed painkillers for long time, then and patient is already having kidney disease because those. So I just go through the various prescription, make a list of that, and suppose patient is going to for cardiologist, he is also prescribed SGLT2 inhibitors, and I am also prescribing SGLT2. So double and polypharmacy must be. So I make a detailed list. I make sure to communicate properly with the different specialists as a primary care taker of the patient, and then I take patient preference, educate the patient that these are the medication are doubling, so I'm not writing this medicine. I write down that this medicine is given by this, so continue this, continue this medicine, this medicine. So communication with other specialists, making a proper list, finding some time to make patient understand that why is taking this kind of medicine. According to me, I handle this with this.
Sure. So, Dr. Chintan, if we hold you on that, how practically this is happening? So, definitely you're doing it, but how much it is happening in real world? I think there is no data, right? It will be your guesswork, in your experience.
So, like what we can do is we can try and make sure that our patients are, there are some patients taking Ayurvedic, homeopathic medicines also. So that we do not know, but we can say that, okay, these are the medicines and you should avoid painkillers. So whenever you go to some surgeon, orthopedic or some general practitioner, ask them not to give them painkillers or this kind of drugs.
Sure.
And educate the patient, make a list of some qualified doctors are giving some prescriptions, then make a list that specialty accordingly, they give this kind of drugs.
Sure. Thank you, Dr. Chintan. So, Dr. Kulshreshtha, now that the patient is with you in the clinic, we have seen the multidisciplinary aspect here. When you are setting the goal, does HbA1c take the center stage or any other parameter takes the center stage?
Sir, it depends the diabetes, duration of diabetes. If it is a recently diagnosed, then obviously HbA1c is the first goal. But if the patient is having diabetes for a longer duration, say more than 5 years or 20 years or 10 years, then it becomes secondary. Then the first and foremost will be lipids. I will try to control lipid first, lipid at a very tight control.
Okay.
Then blood pressure, and then hyperglycemia, that is sugar. So that depends. If the patient is recently diagnosed, obviously I will like to have a very, very tight control. That will be my approach.
So for the audience, it is important to know that each patient they can profile and they can compartmentalize this based on the age group, based on the kind of comorbidities they have, and then on the basis of that prioritization, then you try to approach it. The idea is we don't do any harm, right? And we focus on what is very important for them.
Not only do harm, but prevent also.
Of course.
That is the most important part, because with the, suppose a patient is having diabetes for 20 years, so I would like my first priority will be to avoid hypoglycemia.
Sure.
And obviously, I have to prevent the complications, so statin and antiplatelets and renal protective drugs will be there.
Sure. So while talking, I was just looking at the composition of the chair, the panel, and the moderator. We all are men here. And there's not even a woman on the stage, unfortunately. Somehow we missed it, right? Apologies. So, Dr. Solanki, I'll put you on a spot here, and sorry for that. From a woman's point of view, a patient with women, what are the other core morbidities that you deal with?
Usually, in a women, usually they are mostly in a postmenopausal, osteoporotic, or having some fractures. These kind of things we have seen more. On top of that, in a more elderly women, we'll have to screen them for certain malignancy as per their age-specific criteria and according to the family history. Otherwise, the treating the patient, that does not make, because we are always providing the guideline-directed medical treatment, which is probably focusing to the all organs particularly, and our two stalwarts like Dr. Sanjeev Phatak, Dr. Bansi, they are sitting here, they have set the goal of ABCD, where right from the, in a current time you manage the sugars, and over a long run you focus on the HbA1c, always on lipids, blood pressure, foot care, eye care, skin care. So probably it will be a wholesome care, which is guideline-directed medical treatment involving protection of all organs and control of diabetes.
Thank you, doctor. Can you take the mic, please?
Particularly in the female group of patients, in presence in on an average, all the patients are on SGLT2 inhibitor. It is always better as a physician to thoroughly gynec examinations and look for the whether patient having underlying recurrent UTI infection or post-void residual urine is there or not. So that you have to very much clear before starting SGLT2, particularly in female group I'm talking. It's very common in female. We teach male and female both the patients before starting the SGLT2 group of medicines for this genital hygiene, because once the patient end up with the infection, then it will be going to a big challenge for physicians to handle it. So always keep in mind for any female patient, whenever you prescribe particularly SGLT2 in diabetes management, you have to ask for the urinary tract infection history or not.
Yeah,
and
absolutely.
if possible, you can, particularly in senile group of patients, ideally gynec checkup is also required.
Yeah, I agree, and I remember in 2003-04 when I was involved with BMS developing dapagliflozin, this whole fear factor was so enormous that we as a company weren't very sure whether the drug will move ahead. And today it's very different. But now, courtesy people like
one
you. One
example I am giving you, one of patients because of this genital urinary tract infection has gone through a severe mental stress phase. Because of that infection, patient might have consulted dermatologist. Dermatologists advise all the HIV and all other tests. And by the times they came to the diabetologist, they came to know it's because of the SGLT. Stop it, you will get everything all right. So that 10-15 days of that patients because of that infection, you just can imagine. Because this is it's our duty of the physicians to explain to all the patients before starting SGLT2 inhibitors for prevention.
Sure. I think this is about SGLT2. I can let the panel think about if any other medicine they would want to talk about from, a similar concern point of view. Then
glitazone, particularly in senile group of patients, you have to look for the underlying, as Bhagirath has rightly mentioned, a patient having underlying osteopenia or osteoporosis or not, it's very prone to get the fracture chances.
Yeah.
So that you have to take care, particularly in that group of patients. And beside that, AGI group, a patient having underlying GI upsets or some GERD history or some IBS is also very head-to-head come with the all the diabetic patients. So if patient having that type of history, you have to use cautiously, particularly these group of drugs.
Sure. Thank you. Anyone wants to add? Yeah, please, Dr.
For
Solanki.
glitazones, it is also there that in a perimenopausal woman, when we are using, or premenopausal, it stimulates the ovulation.
Yeah.
So the focus on concept on the contraception is more important. Otherwise, if your patient is already facing so many problems, on top of that, she'll end up with an unexpected pregnancy.
Yeah. Yeah. Thank you so much. I think so. This is the aspect about this topic, right? Practical diabetology. Not easily you will find them in the textbook. So thank you for being here. Coming back to Dr. Chintan, we were talking about the practicalities and the clinical guidelines that Dr. Solanki said that, it is all mentioned. There are algorithms, looks very easy, right, on the screen that, take left turn, right turn, go straight, stop. How do you see that in practical life, implementation of these guidelines in your clinical practice?
These guidelines provide framework to work upon, but clinical practice requires more flexibility because we have to consider so many factors like age of the patient, duration of the diabetes, then affordability is also one of the issues. If we treat according to guideline but patient is not affording, then we are like stuck up. Also accessibility is also one of the issues where guidelines, though guidelines provide framework, but this kind of flexibility, particularly patient with everything, we require other from on the basis of guideline, but choice of the drug. Like we use RSSDI guideline because it provides so many aspects, like starting from the financial aspects. So that also we need to think. So in practical diabetologies, we take cues from the guideline, but clinical flexibility, simplicity, access, and other comorbidities we see, and according to patient preference, we formulate our prescription so that the adherence to that things can be established.
Sure. So, Dr. Kulshestre, we heard that RSSDI guidelines are there, but definitely the audience has an access to American Diabetes Association, endocrinology, European, and then Indian. So, what do you recommend? What our audiences should look at? Which kind of guidelines? Or how to consider one is better or the second is not?
Every guideline is a gold mine, but RSSDI guidelines, they are the most practical,
Yeah.
especially for our population. And basically guideline means, as the word says, it is guideline. It's not that you have to stick to it. You just take it into consideration and then devise your strategy. Diabetic patient, every single patient is a different patient. You cannot treat, two patients with the same prescription. So there are different age, what is the age, duration of diabetes, then comorbidities, then weight of the patient, then financial accessibility to the medical system. So all these factors you have to take into consideration. There are few drugs in which you don't need monitoring too much, but there are, on the other hand, there are drugs. If the patient is having comorbidity, then you have to monitor them. So that is what I will do.
Sure, I agree. So, of course, the question that which guideline is better is the wrong question, the way I asked it. But the idea was to provoke and to see, the audience get the message that guidelines are guidelines and you have to use your practical understanding looking at the patient. You wanted to say something, Dr. Solanki? Okay, sure. So coming back onto the core aspect of diabetes management, hypoglycemia. How small or big is an issue? Dr. Solanki.
Hypoglycemia is a real threat because at the time of diagnosis only we explain to the patients that hyperglycemia is a perceived threat over a long duration. And we see all the patients are not developing all the complications because of hyperglycemia, even if of more than 2 or 3 decades of diabetes. But hypoglycemia can pose an immediate risk to the life of the patient himself or the surrounding people. Suppose a person is a driver and diabetic and he develop hypoglycemia, we can understand the impact of other people who are traveling along with him and is driving the vehicle. So hypoglycemia is a real immediate threat. Hyperglycemia is a perceived threat. That does not mean that we should allow the hyperglycemia. But hypoglycemia should never happen. So whatever guideline-based treatment we are offering to the patient or patient is towing that line, hypoglycemia should not happen. For that, person has to understand the importance of the drugs, their compliance, and the dietary regime. Otherwise, person keep on taking because it is happening sometime. They are having some intercurrent illness and not taking the enough meal and they are taking their insulin or the drugs and they'll end up with hypoglycemia. And hypoglycemia itself is also responsible for various arrhythmias and increase in the cardiac mortality. And subtle hypoglycemia is responsible for cognitive decline of the patient over a short to medium time, where physician also don't understand why this patient is having this much of cognitive decline, what neurologists will call as a vascular dementia, beginning of, or pre-senile dementia. Thank you.
Thank you, Dr. Solanki. So, go ahead, Dr. Chintan.
So hypoglycemia risk overrides everything. I suppose, particularly those who are particularly elderly and renally impaired patient. Each and every decision should be taken considering the hypoglycemia risk first, and then the other things come after.
So, elderly and renal, early renal. Any other profile you want to share with the audience, or Dr. Jitendra Bhai?
It is always better practice as a physicians to tell all your patients whenever you prescribe any medicines, any group of patients with any underlying comorbidity, hypoglycemia, anytime patient notice blood sugar below 100, give alert to the treating physicians. I always say to all the patients, તમારું સુગર 200 હશે તો હોસ્પિટલ સુધી પહોંચી વળશે, પણ 20 થશે તો 108 બોલાવવી પડશે. So you counsel your patients whenever you notice any blood sugar reading below 100, immediately inform to your treating physicians. So by that way you can take care of hypoglycemia complication prevention. And again, the selection of group of patients, particularly those who are at very high risk, in that you should not be so aggressive for hyperglycemic management, particularly for prevention of hypoglycemia, like CKD group patient having underlying heart failure or coronary artery disease, or very high risk of coronary patients, fragile, senile patients. In that, you should not be very aggressive to invite these complications to create the problems for the patients.
Sure, sure. Doctor, just a minute, Dr. Chintan. We go to Dr.
The patient who are having diabetes for more than 10 years, it is always advisable to stick to the go very low in managing sugar. I always advise my patient that your sugar will be, should be between 100 and 200. If it is go beyond that, you always contact your physician. And hypoglycemia is a life-threatening situation. And if once a patient goes in hypoglycemia, it is very difficult to convince him to continue the medicine.
Yeah.
It takes extra effort to make him understand that medicines are required actually.
Sure. Dr. Chintan?
Yeah, I remember one incident a few years ago that one patient from London came to me, and I just see his prescription, and he was driver there, bus driver, and he categorically told me, don't prescribe me sulfonylurea because I am not allowed to take sulfonylurea.
Mm-hmm.
So maybe at that time the newer generation was not available, but they were like prescribing, we can give ripaglinide but cannot give sulfonylurea.
Thank you.
In connection to your this hypoglycemia question, I would like to convey one message. All diabetic patients should teach enough that any additional medical illness along with ongoing diabetes treatment, if you have some diarrhea, vomiting, or some febrile illness, if your family physician is treating you, and if you are sick and not eating enough, take your diabetes medicine after in consult with your treating physicians. Number one. Number two, if you are doing fast unnoticed without informing your physicians, these two things we have to teach our patients, that don't do fast without taking consent from your treating physicians. And if you notice any febrile illness or any sickness or any other surgery, please contact your treating diabetologist.
Sure. Thank you. Dr. Solanki, you want to add some point here on hypoglycemia? You're okay? So let us then come to polypharmacy. You did also, Dr. Solanki talked about it. So while you have a profile of a patient where hypoglycemia can happen, how, while looking at a prescription, when a patient comes to you, say from some other place, and now you take charge of this patient, you predict or you think that, with this prescription, there is a high possibility for a patient to have hypoglycemia?
Say, we already know, all practicing physicians, that the diabetic medications we have grossly divided in two parts, hypoglycemic and anti-hyperglycemic. Anti-hyperglycemic are not so potent and would seldom cause hypoglycemia. I need not to say that they cannot cause, but they very less chance. But hypoglycemic treatment, in particular, what Dr. Chintan have said, sulfonylureas and insulin. Whenever we come across the hypoglycemic patients in our tertiary care hospital, mostly these two drugs are incumbinated. Patients are, and mostly it is glimepiride, and that is why we have to continue them the IV glucose for almost 36 hours. And we have seen some patients going for recurring hypoglycemia. even beyond 2 days or so. So sulfonylurea, short acting, will be having a short lasting hypoglycemia. Glimepiride will have a long lasting hypoglycemia, and insulin depends on the use, because as Dr. Jitendra Bhai have told, that person continued taking the injections and not taking meal because of some fast or because of some intercurrent illness, the person will have hypoglycemia. And this is seen mostly in elderly patients, where out of ignorance probably they are continuing, and the caregiver are also not, the person may be knowing, but the caregiver do not know. So the household person will always give the medicine. Okay, you take this medicine, at this time you have to take this. Doctor have told you. So person continue the medication, but he is not continuing the enough diet according to his profile, and that results in hypoglycemia. So I think what we have seen is only these two varieties of drugs which are incriminated or responsible for hypoglycemia, and we usually, and this is happening in patients who have what we can say just early CKD. There also the chances of hypoglycemia, because what is happening in the natural history of diabetes, sometimes patients say કે સર મારું તો સુગર બધું 200 રહેતું હતું, હવે તો 200 થી નીચે આવી ગયું. That gives an alarm to the physician કે I need to check creatinine, I need to calculate EGFR, I need to check USCR, because that is responsible for the triggering of the hypoglycemia with the pre-existing treatment, because patient has developed early CKD.
Sure.
So
thank you.
Yeah.
So in connection to your question of polypharmacy, so how you will prescribe in your day-to-day clinical practice, with the availability of all the triple drug, dual drug combinations, the benefit of giving this polypharmacy with minimum pills. So the benefit is that adherence to the therapy and full therapeutic dose we can pass on to the patients to take the good control of diabetes. But at the same times, you have to customize your prescriptions by looking at the patient's consumption of their meals. So you have to take the detailed history of your patients, at what time he is consumed major meal, whether he is taking heavy lunch or whether he is taking heavy dinner or heavy breakfast. Then these all the combinations, whether it is with SGLT2, DPP4 or metformin or sulfonylurea with other drugs combinations, you have to look into the patient diet intake first. Then and then these poly pills you can prescribe. Otherwise, it will end up in the big problem of hypoglycemia. Sure. So that point has to be keep in mind whenever you prescribe dual or triple drug combination for any patients. Bhagirath has rightly mentioned that any combination with sulfonylurea is very, very dangerous. They are very likely to get hypoglycemia risk. So be careful whenever you prescribe any triple drug or dual drug combinations along with the sulfonylurea group. It's very safe to give very less hypoglycemic agent, DPP4, SGLT2 or metformin combinations to any patients blindly without, if you don't have, you are very busy in clinical schedules, you can blindly prescribe. But if you're prescribing sulfonylurea, make sure patient is consuming adequate food. That always you have to keep in mind.
And the irony is that the medicine that you're talking about, sulfonylurea, they are one of the most affordable medicines. And now if I take this clue to the next question, and Dr. Anil, how do you see cost affordability as an issue in choosing ideal therapies?
Luckily, in Ahmedabad at least, all drugs are available at a very economical
Very nice.
except GLP agonist. See, now linagliptin is available at 2.5 rupees only. So I think controlling diabetes with newer drugs is not difficult in Ahmedabad and Gujarat at least.
That is very nice to hear.
So because of the off-patents of all these SGLT2 and DPP4 and availability of economical combinations in present era, sulfonylurea we use in the least dose of, because we would like to pass on the benefit of sulfonylurea in all the patients. So we start with 0.5 milligram of glimepiride rather than jumping to 2 or 3 milligram combinations. We give full therapeutic dose of DPP4, SGLT2, metformin, if required low dose of pioglitazone. but we'll keep sulfonylurea particular in this prescription on the bottom side. So we can pass on the benefit of all the drug combinations for better control of diabetes.
Sure. Thank you, Dr. Jiten Bhai. We have 4 minutes left. I have 4 questions left. So maybe in less than 1 minute, Dr. Chintan, lifestyle advice. How do you see this playing a role? I mean, we had the nutrition session before that. As a physician, how do you approach it, and how do you see it as a challenge or opportunity?
Yes, I would like to say that for lifestyle advice, I would put not overwhelmed patient directly by giving him or her very high goals, like losing 20 kg weight and kind of things. I would give him small breakdown of and motivate him or her to cultivate good habits rather than going directly on the goal-oriented things. I would give the process more important than achieving the goal, and small success will come along with the goal when you change the lifestyle according to, and this is how I approach my patient. And don't overwhelm that you do this, that, and they would get more frustrated and will lose the control over them, and they will ultimately give up.